From the 20th of March 2008, the Aged Care Funding Instrument, or Acfi, will be used to allocate government care funding to residential aged care providers. It will replace the previous Resident Classification Scale, or RCS, system. Under Acfi, aged care providers will have a better model to assess the care needs of their residents and calculate the funding to be paid by the government for each resident in their care.
Well, Acfi is here. It's a good change. There's much less paperwork, and this gives us time to do what we really want to do, and that is look after our residents.
Another benefit of Acfi is that the system will reward positive outcomes for residents.
In the current system, homes are required to reappraise residents each year, even if there's no change in the care needs. Now, we recommended that this be changed. The government accepted this, and as a result, Acfi classifications won't usually expire. This gives providers a financial incentive to provide rehabilitation and further support to residents. If homes manage to improve a resident's condition, then they get the benefit of the reduced care costs without reduced subsidies. More importantly, the resident will have a better quality of life.
All residents who enter care from the 20th of March 2008 onwards will need an Acfi appraisal. Residents who enter care before then will continue to need an RCS appraisal. The new Acfi system uses 12 questions and 2 categories of diagnoses, which will classify residents as having low, medium or high care needs in each of these 3 care domains: activities of daily living, behaviour, and complex healthcare. For each question on the assessment, there are checklist responses. A rating key for each checklist will determine a rating for each question. Then a score of A, B, C or D is given for each question. The combined scores will determine eligibility for funding and whether this is at the low, medium or high level.
I think it's a simplified and fairer measure of a resident's care needs. The RCS puts people with very different care needs in the same category. For instance, a resident that is ambulant with dementia can be put into the same category as a resident with poor mobility that has full cognition. But Acfi recognises those differences because it puts like with like.
As well as reducing the number of questions from 20 to 12, Acfi will also collect diagnostic data.
I like the new system. It's going to give us much better information about our residents. For example, the old system didn't provide any diagnostic data, so there was no information available nationally about the medical conditions of residents and how these might change over time.
The Acfi focuses on those areas of care needs that best distinguish the costs of care between residents. The assessments have been designed to provide a nationally consistent method of categorising residents for funding in a manner that is consistent with good care practice.
Well, the fundamental difference is that Acfi looks at a resident's assessed care needs, whereas the old system looked at the care planned or provided for the resident. I believe the Acfi provides a fairer way of determining relative care needs and an accurate basis for the funding model.
And it's hard to actually put a resident into a box or a category, whereas Acfi has a much more individualised approach.
We knew Acfi was going to be a better system in theory, but however we need to put that in practice and get the real life data. The trial showed us the workload impact is very good, and the assessment process is simple and quick and efficient. The old model RCS looks at care provided, which is pretty subjective, whereas the new model Acfi looks at the core dependencies of people, which is much more objective.
One of the really positive things about Acfi is that the appraisal pack contains all defined records, which is a really positive thing because it reduces the amount of paperwork involved. I think it's good to review the way that you document care to see that it's done as best and efficiently as possible.
The Acfi system will require tightly defined evidence, and that will reduce the frequent overuse of documentation.
The way the department will validate under Acfi will be different too. Validators will only look at the Acfi appraisal pack for documentation, which will significantly reduce the amount of paperwork required. They may also observe and assess residents, interview staff or other informed persons.
We understand that you might have some concerns about the upcoming change. So let's have a look at some frequently asked questions. When do I start doing Acfi appraisals?
From the 20th of March 2008, all new residents who enter into an aged care facility will go on to Acfi appraisals. Any existing residents whose classification expires from that date will then go on to Acfi appraisals.
Who can do an Acfi appraisal?
Aged care staff can complete Acfi appraisals. We think it's important that the person who is experienced with the assessments and best knows the resident's usual needs should be the one to do it.
Will the Acfi reduce pressure on staff?
Acfi will greatly reduce the pressure on our staff. They no longer need to go through nursing notes, care plans to complete the Acfi appraisals. It took less than 1 hour to complete the Acfi appraisal in the trial.
Will our current IT systems need to be upgraded? Each aged care facility will need to check with their software vendor regarding upgrades to their IT systems. Online Acfi transactions will be available from the 20th of March 2008 through Medicare Australia's Aged Care Online Claiming System. Under Acfi, aged care providers will have a better model to assess the care needs of their residents and calculate the funding to be paid by the government for each resident in their care. The Acfi funding model will match resources to residents' needs accurately, which means residents that need higher care will have increased subsidies. There is no therapy rating in the Acfi. Does this mean that we no longer have to provide physio or other therapy for our residents?
Well, the Acfi model will not change any approved provider responsibilities. You'll still need to provide the appropriate care and services that meet the individual assessed needs of a resident. The difference in the new system is that the Acfi doesn't ask about what therapies you'll actually provide. It simply allocates funding based on the assessed need for care and support.
How often or when do we need to reassess residents on Acfi?
We have to reassess a resident when their funding is due to expire. When a resident comes into our facility, it's directly from hospital, after 6 months we will have to attend to a reappraisal. Most Acfi classifications won't expire. However, we can choose to reassess a resident any time after 12 months.
Do we need to keep ongoing records just to prove that our Acfi appraisals are accurate?
Under Acfi, we only need to keep the Acfi appraisal pack for each resident. This will greatly reduce our time spent on paperwork and let us concentrate on caring for our residents. We will of course still need to keep care planning records as part of our quality processes.
Can I reappraise existing residents who have an RCS classification before it expires?
You can only reappraise existing residents prior to expiry if there's a major change in their care needs. A major change means that the new rate payable under Acfi is $30 or more above the existing rate.
How is the Acfi rate calculated?
Well, the Acfi rate is the sum of the amounts payable for each of the 3 Acfi domains.
Do we get less for a resident if the Acfi rate is lower than what is currently being paid? You will get the Acfi rate for an existing resident where the amount payable is $15 or more above the resident's RCS rate. If it is less than this amount, you will continue to get the existing amount. What will the Acfi validation process involve?
Validation will be different under Acfi. For a start, unlike the RCS validation, it is not just a documentation review. CNOs will be able to look at the resident and this can tell them a lot.
The first step is to look at the claim and then make sure that that's complete and accurate. Secondly, we'll do a congruence check to make sure that the documentation paints a sensible clinical picture of that person. That may be the end of the process for some claims. However, where there is incongruence, we may seek further information by either interviewing staff, the resident or their families. We may even assess the resident's impairment by using simple task assessments. We're just trying to confirm that the Acfi appraisal accurately reflects the resident's usual care needs at the time it was completed by the aged care home.
What happens if the validator gets a different score on the assessment? Will they downgrade us?
Well, let's say that a Commonwealth nursing officer completes a validation and finds a different score. For example, the officer's score on the psychogeriatric assessment scale suggests a minimal, not a moderate or severe impairment. Now, instead of an automatic downgrade, this would signal a need for further inquiry. The officer would then interview senior staff to get a better understanding of what might have been affecting the cognitive status of the resident at the time of the appraisal.
During recent trials, over 5,500 people had Acfi appraisals. The results show that Acfi took less than an hour on average to complete.
Which means under Acfi there will be less paperwork so our staff can do what they do best, look after our residents.
During the trials, there were also positive results on validations. External assessors agreed on over 95% of questions with the aged care staff.
This means there won't be as many downgrades, subsidies won't decrease, and there'll be more funding for aged care.
The Acfi is not designed to be a comprehensive assessment tool for care planning purposes, but it is much more consistent with good assessment practice. To make the transition into the new system a little easier, homes will have an extra month in which to submit appraisals for residents who enter care in the first month after Acfi starts. Let's now recap on some of the main points you need to know. Acfi starts on the 20th of March 2008. All residents who enter care after this date must have Acfi appraisals. Existing residents will change to Acfi once their RCS expires. You will get the Acfi rate for existing residents if it is $15 more than the current rate. You can reappraise existing residents before expiry if they have a major change, which is $30 above the current rate. Homes have an extra month to submit appraisals in the period from the 20th of March to the 19th of April 2008. If you want to know more, the Department of Health and Ageing website will be updated regularly, or you can call the Aged Care Helpline on 1800 500 853.
Right, we're about ready. You all set, Sharon?
Yeah. Just gonna have a sip of water. Not feeling too good today. Okay, good to go.
Right, this is an interview with Sharon Barker for infection control. Can I have a board, please? Right, first off, Sharon, just tell us why infection prevention and control is so very important for anybody working in a care home.
Well, I'm no expert, but I know it's essential because of the increased risks. It's something... because... Sorry, I'm just not feeling too good.
That's all right, we can pause.
Actually, I think I'm... sorry, I'm just gonna... Sorry.
Are you okay? You all right?
Sorry I'm late.
Oh, we weren't expecting to see you. I heard you weren't well yesterday.
Yeah, it really wasn't good yesterday. Probably something the kids brought back from school. Much better today though, and I didn't want to let anyone down.
Oh, you are a trooper. But Naomi already said you weren't expected today because of the risk of spreading it, so you best head home.
Are you sure? I know we're a bit short-staffed at the moment.
I'll tell Naomi you popped in, but we'll get someone from the second floor to come and cover you. You head home. Oh, but can I quickly get you to sign this whilst you're here?
Okay. If you're sure you can all manage, I'll head home. Thank you, Sharon.
It's no problem.
Oh, is that a filming thing coming up soon, isn't it?
Yes. Eek. I don't know what I'm going to say. I hate being on camera. Wish me luck.
You'll be great. Good luck. See you, Sharon.
Feel better soon.
Infection prevention and control practices need to be ingrained as a natural part of everything we do. It's essential to providing safe, quality care. It should be automatic, but as we're about to see, it's easy for poor habits to creep in when we're busy, despite our best intentions. So let's find out exactly what we need to watch out for and why good infection prevention and control is so important for anyone working in a care home.
Come in. Good morning, Georgina. How are you feeling today?
Hello. Not too bad, thank you. I can't complain.
Good. I'm just going to pop your bed up if that's okay.
Yes.
Is it okay if I just check to see if your dressing's all right, and then Meg will be along in a few minutes to help you get dressed?
Of course, dear, yes.
I'm just going to pull your covers back if that's okay. Oh, excuse me, Georgina. I'll just put my gloves on. These things are so fiddly. I hate putting them on really, but...
Do you think you could pass me that glass of water, please?
Of course. No problem.
Thank you, dear.
Now, how's it feeling today? Is it still sore?
It seems a bit better now, thank you. Yes?
Yes, it's looking much better, so you'll be pleased to know we don't need to bother you with changing your dressing today.
Thank goodness. So silly of me. I must be more careful next time.
Not at all. These things happen. Just give my hands a quick clean.
Yes. Do you know, it's so good, so nice to be back in my own bed.
I bet it is. We're glad to have you back. We missed you whilst you were in hospital. Now, are you quite comfy if I leave you for a few minutes until Meg arrives to help you get up?
Yes, thank you. I'll just try and finish this before she comes.
Lovely. I'll just put your bed back down. That's okay.
Oh, yes, thank you.
There we go. It's quite fun going up and down on these beds, isn't it? Right. I shall see you soon.
Yes, bye-bye.
Sharon wore personal protective equipment. She cleaned her hands, so she was obviously thinking about infection control. Or was she? How many infection prevention and control issues did you spot? You can take a note of them now. Have a think about it, and later we'll come back and take another look. But first, we need to know how infections are spread and the standard precautions we should be taking.
There are 6 links in the chain of infection: the organism, the reservoir, a way out of the body, the method of transmission, a way into the body, and the person at risk. An infection or illness occurs when microorganisms multiply inside our bodies. In sufficient numbers, they can cause us harm. Microorganisms that cause infections are called pathogens or infectious agents, or sometimes just germs, and there are many different types. Bacteria, like E. coli, or Clostridium difficile. Viruses, which cause things like the common cold, influenza or gastroenteritis. Fungi, such as thrush or ringworm. Parasites which live on a host, like scabies or head lice. And multi-resistant organisms, types of infectious agents that have developed a resistance to antibiotics. These infectious organisms are generally invisible to the naked eye, and they're everywhere, on everything we touch, including in and on our bodies. That's the second link in the chain, the reservoir. Anywhere that germs gather, a light switch, a lift button, a phone, food, water, surfaces, handrails, pets. It's why thorough cleaning is essential, alongside effective procedures and correct equipment for the management of laundry, clinical waste and spills. And you can find out more about those aspects of infection control in your ACC library. A reservoir could even be as simple as a keypad, or us. So we need to think about all the places where we might harbour germs, our uniforms, the edges of our nails, or around chipped nail varnish, the tiny areas and joins in jewellery that are impossible to clean properly. That's why good practice requires us to be bare below the elbows. Nails should be short, no nail varnish or false nails, no watches and no jewellery, besides a plain wedding band. The next link in the chain of infection is a way out of the body, which could be via bodily fluids like faeces, urine or blood, flakes of skin or loose hair, or simply a cough or a sneeze. So hair needs to be tied back. Cuts and abrasions need to be covered with a waterproof dressing. And we must follow cough etiquette. Cover your mouth and perform hand hygiene immediately. If you don't have a tissue to hand, cough into your elbow. That way, you're also breaking the fourth link in the chain, the method of transmission. One of those methods is via droplet. Tiny droplets containing infectious agents go into the air when we cough, sneeze, or even just talk, and they settle on other people or surfaces. Next, there's airborne transmission. Very small particles containing infectious agents are spread via the air and can be breathed into the body. Then there's direct contact, which is when we touch an infected person, or infected blood or bodily fluids, such as urine or saliva. So it's important to wear personal protective equipment when handling soiled items and hold them away from your body to avoid contaminating yourself. And finally, there's also indirect contact, when we touch a contaminated surface. Now the infectious agent just needs a way into the body, and that could be via a break in the skin or mucous membranes like the mouth, eyes or nose, or by ingesting it via contaminated food or water. To minimise the chance of infection finding its way into the body, extra precautions need to be taken around clinical procedures, as well as the handling of medical devices, such as catheters or sharps. Needle stick injuries pose a significant risk, so all sharps need to be handled and disposed of according to your organisation's policies and procedures. If an infectious agent does find its way into the body, that brings us to the final link in the chain, the person at risk. We can all get infections, but people receiving care are at a significantly increased risk. They're more likely to come into contact with infectious agents when visiting healthcare settings like hospitals. They're more likely to live with invasive devices like catheters, or to have wounds like skin tears or pressure injuries. All of these provide entry points for infection. Poor mobility may also make it more difficult to maintain personal hygiene. Conditions like dementia or poor eyesight may make people less aware of infection risks. And the immune system is weakened by age, illness, and possible dehydration or malnutrition. So it's important to encourage people to drink at least 1,500 millilitres each day and to eat well. The immune system can also be compromised by some medications and treatments, like chemotherapy.
I heard a film crew is going to be visiting. Are you doing something with them?
I am indeed. I'm filming an interview for a medical training film. Gonna be a big star, Bill.
I'm sure you will be.
All these factors mean people receiving care are not only at an increased risk of infection, but they also find it harder to recover. The effects can be severe, even life-threatening. That's why standard precautions we take are so vital. It's why we can't afford to become complacent. We have to break that chain of infection. So, how many issues did you spot in that earlier scene with Sharon and Georgina? Let's take another look.
Good morning, Georgina. How are you feeling
Hand
today?
hygiene should be performed before contact with the resident. Whenever you're handling sheets, fold them back carefully to contain any infectious particles, rather than spreading them all around. Remember droplet transmission. Cover your mouth and clean your hands straight away. Hand hygiene should be performed before putting gloves on, as well as after taking them off. And if we store gloves in our pocket, they're of no use, because then they're not clean gloves. If we touch something else when we're wearing gloves, then either the gloves become contaminated or they spread contamination. So again, they're of no use. Gloves should always be worn if there's a likelihood of coming into contact with bodily fluids, non-intact skin, or mucous membranes. Plastic aprons should be worn if there's a splash risk from bodily fluids. Gowns, face masks and protective eyewear may be required in certain situations, such as if a splash risk is identified. Personal protective equipment is essential to preventing the spread of infection, but it's only effective if it's used correctly. We have to think about exactly what we touch while we're wearing gloves. We need to wear fresh gloves to attend to each person, and they should be changed whenever you begin a new care-related task with that person. They should be discarded immediately after use, and they are never reused. We also have to think about how we take them off. Have you ever rushed and done this? Whipping off your gloves too quickly just means we're spreading contamination. So, here's how we need to do it.
Pinch and hold the outside of the glove near the wrist area. Peel it downwards, away from the wrist, turning the glove inside out as you go until it comes off. Then hold it within the other hand that's still gloved. And with your ungloved hand, slide your fingers under the wrist of the remaining glove, taking care not to touch the outside of it. Again, peel downwards, away from the wrist, turning the glove inside out so that it encloses the glove you've already taken off. This ensures that both gloves are inside out, one glove enveloped inside the other, with any contamination contained on the inside and not on your bare hands. Removed gloves go straight into the appropriate waste, and we perform hand hygiene. Remove goggles. Then, if you're wearing an apron, the same principle applies. Remove it by folding the outside edges inwards and wrapping it up, so that any contamination is contained on the inside. Then dispose of it in the appropriate waste, and perform hand hygiene again. Leave the room. Remove the face mask. Perform hand hygiene again.
You might think hand hygiene is a pretty repetitive business, but that's because everything we do involves our hands. They're reservoirs and they transmit germs. So hand hygiene is the single most important aspect of good infection prevention and control. Sure, Sharon performed hand hygiene. She obviously meant well. But did she do it at the right times? No. Did she follow the correct steps? No. So did it help prevent the spread of infection? No.
Hand hygiene needs to be performed at the right times, according to the World Health Organization's 5 moments of hand hygiene. Before touching a resident. Before a clean aseptic task. After body fluid exposure risk. After touching a resident. After touching a resident's surroundings. For a full list of all the times when you need to perform hand hygiene, refer to your learning resources.
I'm sure we've all seen those hand washing posters about. And here's the simple reason why we have to follow them. Imagine all that glowing is from the infectious agents on your hands, the germs you've just picked up in the course of going about your day. Pretty obvious which hands were washed correctly, isn't it? So if ever you're busy or in a rush, and maybe you're tempted to cut a few corners, just think of all those potential germs. They may not cause you any harm, but for a person at increased risk, they could be the start of something serious. So take those few extra seconds, be aware, and wash with care.
An effective hand washing technique should take a minimum of 20 to 30 seconds. Wet your hands thoroughly under tepid running water before applying soap. You need enough soap to cover all of the surfaces of the hands. Then rub vigorously using the following steps. Palm to palm. Right palm over the back of the left hand with fingers interlaced, and vice versa. Palm to palm with fingers interlaced. Backs of fingers to opposing palms with fingers interlocked. Rotational rubbing of left thumb clasped in right palm, and vice versa. Then rub the fingertips of your right hand rotationally in the palm of the left hand, and vice versa, to really get into those tricky nail and cuticle areas. Rinse hands thoroughly and dry thoroughly with clean paper towels. Any residual moisture provides the perfect environment for bacteria to multiply. Remember, as soon as you touch anything else, your hands become contaminated again. Taps and bins are reservoirs for germs, so try to use your elbow or a paper towel to switch off taps and avoid touching bins. All this regular washing can make the skin dry out, so use good quality mild soap and moisturise regularly.
If you use alcohol rub for hand hygiene, you need to follow the exact same steps as hand washing. This ensures that every surface of your hands is covered, otherwise it isn't effective. Alcohol hand rub is the preferred method for hand hygiene, except when hands are visibly dirty or if there's a potential for the spread of alcohol-resistant organisms like Clostridium difficile spores or other pathogens that cause diarrhoea, such as norovirus.
Hi Bill, here's your tea.
That's grand, thanks.
I wonder where Georgina is.
Yes, she normally comes down for afternoon tea, doesn't she? Tell me, is that film crew still here? I was very curious as to what they were up to. Sharon said it was an interview or something.
I think they left a little while ago. Poor Sharon had to leave before they finished filming her bit. She wasn't feeling very well.
Oh, that's a shame. Tell you what, I'm not feeling too wonderful myself.
Oh, really?
Could you help me back to my room, please?
Of course. Let's have a word with the nurse as well, shall we?
If we don't follow standard precautions and someone becomes ill, or there's an infectious outbreak, we can't rewind the clock to fix things. So we need to be thinking about infection prevention and control all the time. We need to take action to break the chain of infection at the first and every opportunity. If Sharon could rewind the clock, what might she have done differently? What was her first mistake?
Hello?
Oh, hi Ben, it's Sharon. How are you feeling? I heard you weren't very well yesterday.
Oh, yeah, really wasn't good yesterday. Much better today, though. Sorry I'm late, I am on my way in. Didn't want to let anyone down.
Oh, thanks Ben. But actually that's why I'm calling. I wanted to catch you before you arrived. I wanted to remind you that you need to stay off for at least 48 hours after the last symptom you had. So sorry I couldn't call earlier this morning.
Oh, that's okay. Are you sure? I know we're a bit short-staffed at the moment. I don't want to cause you any problems.
Oh, it's no problem. We'd have bigger issues to fix if you passed any bugs around. You stay home, rest up, and we can arrange cover.
Okay, thanks Sharon. Bye.
Bye. Good morning, Georgina. How are you feeling today?
Fine, thank you. I can't complain.
Oh, good. Is it okay if I just take a look to check your dressing? Then Meg will be along in a few minutes to help you get dressed.
It's fine.
I'll just close the curtains. Just give my hands a clean.
Got to be so thorough, haven't you, these days?
Is it okay if I just take your covers back? Thank you. Oh, excuse me, Georgina.
Bless you, my dear.
Excuse me. I'll just clean my hands again.
Another one?
Yes. Got to make sure we're germ-free.
Ah.
Right, I'll just put my gloves on.
They look very awkward.
Yes, they can be a little bit fiddly.
Could you pass me my glass of water, please?
I'll sit to you in just 1 second. I'm going to check your dressing, then I'll take my gloves off and then I'll pass it over if that's okay. How's it feeling today? Is it sore? In fact, you'll be pleased to know we don't need to change your dressing today.
Oh, good. I really must be more careful. It was so silly of me.
No, not at all. These things happen. I'll just clean my hands again. And then hand you over your water. You must be parched by now.
I am parched.
There you are.
Thank you, my dear.
My pleasure.
Thank
I'm going to
you.
pop your bed back down for you.
You're doing really well, Sharon. Now, just one last question. What final message would you give people about infection prevention and control?
We have to protect ourselves and our residents. Infectious agents are constantly around us, so infection prevention is the responsibility of every single member of staff. We cannot afford to forget our standard precautions or take shortcuts.
Great job, Sharon. All right, everyone, we're all finished.
It doesn't take much to break the chain of infection. Likewise, it doesn't take much for infectious agents to spread, just a few little lapses in concentration. In reality, we can't rewind the clock if we forget our standard precautions. Staff can bounce back from infections, but the people we care for might not. So, remember to think infection, prevention and control in everything you do, and get it right first time, every time.
One of the most important aspects of ensuring good health outcomes for older people in residential care is the safe and effective management and delivery of medications. A lot has changed in medication delivery, so now more than ever it's vital to have a clear and systematic approach to medication management. People's lives are in your hands, and getting it wrong can have devastating outcomes. Medications are not just pills. They can be any substance taken to prevent or treat illness or to maintain health. They include prescription and non-prescription medicines, including vitamins and mineral products. They can come in different forms and can be ingested, inhaled, injected, inserted, or applied. The goal of medication management in any aged care setting is to safely achieve optimum health outcomes for the older person, ensuring the quality use of medicines. This means how medicines are selected, ordered and supplied, how people take medicines or how they're assisted to take them, how safely and effectively medicines are used, and how medicine use is supported, monitored and evaluated. Most people in residential care need to take some form of medicine, and many take a variety to treat different conditions. In residential care today, people are often older, more frail, and so more at risk of adverse events and drug-related problems. This means safe and effective medication management is more important than ever. The following case is based on a real event. Names have been changed.
On the 2nd of April, Mrs. Gwen Davidson returned from hospital with her discharge medications, including methotrexate. This drug was prescribed to treat her rheumatoid arthritis, a single dose once a week.
Okay, I'm off. Mrs. Davidson's back from hospital. She's comfortable in her room. Can I give you her paperwork and medication to sort out?
Yep, no worries.
See you in a few days.
Hi, Karen.
This page.
Hey, Robin, how's it going?
Actually, I'm busting to go to the toilet. Could you take care of the discharge paperwork and the medications for Mrs. Davidson? She's just come back from the hospital.
Okay.
Yeah, you just need to check the medications and what the discharge letter says. I'll be back in a sec.
But I haven't completed my competencies.
Oh, you'll be fine. Just follow the paperwork.
Let's see what we have here. Shocking handwriting. Ventolin. 2.5 milligrams. Daily. Oh, she's due for that now. I'll let Robin know. Also, the doctor still needs to chart her meds. Hey, Robin. Here's the discharge letter for Mrs. Davidson. The Ventolin and the methotrexate, it says here daily, so
Okay.
I think she's due for that now.
I'll take care of it.
Okay, no worries. Thank you so much.
Hello, Mrs. Davidson. It's good to see you back. You're looking so well. I have your medication. Are you okay to take it now?
Yes.
Okay, there you go.
Oh, these ones again?
Oh, yeah, no, it's all good. They're on your discharge letter. There we go. All okay? Okay, good. Oh, is that a new photo? That's lovely.
It's another one. It's my daughter and my grandson. They're coming on the weekend to see me.
That will be lovely. All right, I'll see you later. Bye.
Hello, Mrs. Davidson. I'm bringing your medication.
Thank you.
Sorry to interrupt. Raj, when you're finished, I really need to speak to you about Mr. Moore.
I'm just a little busy right now.
Yep, okay.
Here you are. You just need to take this.
Thank you.
Still a bit tired?
Just a bit.
All right. Just rest up, all right?
Thank you.
Oh, hey Raj, could you take over the medication rounds? I've just got to speak to one of the doctors.
Yeah, sure thing, I guess.
Yeah, awesome. Thank you. You'll be right.
Gwen Davidson. Gwen, I'm just got your medication for you. Hello, Mrs. Davidson. I've got your medication. Are you awake?
Yeah, it's okay.
Are you okay to take it?
Yes. All right.
Let me help you. Here you go.
Okay, I might check on you later.
Oh, thank you.
Okay, so that's about it.
Okay, great. You head off if you like.
Actually, Rajni mentioned that Mrs. Davidson wasn't feeling so well this morning. I was going to go check in on her.
That's okay. I can pop in and check on her.
Thanks.
Mrs. Davidson. Mrs. Davidson. Mrs. Davidson. Mrs. Davidson. Mrs. Davidson. Robin, I need help, quick. Call an ambulance. It's Gwen, she's unresponsive. Get someone to grab the oxygen and the obs equipment.
Okay, I'll call the ambulance straight away. I've got the oxygen. I'll be back. Mrs. Davidson's in here. I got everything ready for the ambos.
Can you tell me what's happening here?
She's only been back from the hospital this week. This is her discharge summary and the meds she's been on since she's been back. No way. Methotrexate should be given weekly. We've been giving it daily.
It was ordered for daily, wasn't it?
The methotrexate should be weekly.
Resuscitation unsuccessful. Time of death 16:20.
This was a devastating outcome because at each stage the correct processes were not followed. It highlights the need for a strong medication management system, which includes conducting a root cause analysis following any critical incident to reveal the contributing factors and decide the steps necessary to prevent it happening again.
In the case of Mrs. Gwen Davidson, incorrect procedures led to her being given the wrong dose of methotrexate. Staff were using the discharge summary as the medication chart. The resident's doctor hadn't charted the medication onto the correct medication chart. The medication was administered from a pill bottle, but the facility uses Webster packs, which have inbuilt safety measures that prevent this occurring. Once Mrs. Davidson had returned from the hospital, the medication should have been recharted onto a medication chart and the drug sent to the pharmacy for correct packaging. All these errors led to the repeated maladministration of the dosage, directly causing Mrs. Davidson's death.
There are laws that govern the storage, dispensing, prescribing and disposing of medicines. All staff have a duty of care to safely manage the person's medications within this framework and to maintain their ongoing professional development in this area. Professional bodies create better practice guidelines that underpin the development of policies, procedures and position descriptions, as well as system-based medication management. A staff member's scope of practice is determined by their education, competence, and the authority under which they practice. Staff must work safely within their scope of practice, professional boundaries, and the organisation's policies and procedures. This includes correct delegation of duties and authority. A member of the healthcare team can delegate aspects of the older person's care to another team member. However, it should only be done to meet the older person's needs. which means the right person needs to be available at the right time to provide the right care. The delegator is transferring authority, but always retains accountability for the decision to delegate and for monitoring the outcomes. In the case of Gwen Davidson, the coroner highlighted some of the factors that influenced the outcome.
It was shown that the facility did not follow their procedures for training and delegation. The procedure for charting and packing of medications was not followed. The weekly dose had been mistakenly given as a daily dose. This was not detected as the order was not properly checked. This was compounded by a poorly handwritten order on the discharge summary.
Hey Robin, how's it going?
Actually, I'm busting to go to the toilet. Could you take care of the discharge paperwork and the medications for Mrs. Davidson? She's just come back from the hospital.
Okay.
Yeah, you just need to check the medications and what the discharge letter says. I'll be back in a sec.
But I haven't completed my competencies.
Oh, you'll be fine. Just follow the paperwork.
Let's see what we have here. Shocking handwriting. Ventolin. 2.5 milligrams. Daily. Oh, she's due for that now. I'll let Robin know. Also, the doctor still needs to chart her meds.
Again, when the RN dispensed the medicine to Mrs. Davidson, she did not accurately check Mrs. Davidson's medication chart against the current dose before administering the medication.
Oh, yeah. No, it's all good. They're on your discharge letter.
The RN also delegated the medication delivery to a more junior staff member without a proper assessment of that staff member's competencies.
Yeah, sure thing, I guess.
Yeah, awesome. Thank you. You'll be right.
She also did not follow up to ensure the enrolled nurse had followed medication management protocol.
Gwen, I'm just got your
This
medication
should have
for you.
included the cross-checking of the medication against the medication chart.
The person responsible for the accurate recording and delivery of the correct medication was not diligent in her duties. She delegated this responsibility to a junior staff member. This meant that the staff member with the least medical experience was the last person to administer the medicine. Adherence to the facility's protocols surrounding auditing, dispensing and delegation of medicine were not followed. There was no quality medication management system in place.
Awesome. Thank you. You'll be right.
A quality medication management system is a systematic approach to medication management. It means following the best practice guidelines that cover every aspect, including prescribing, dispensing and labelling, using medication charts, supplying and receiving, storage, administering and monitoring, and disposing of medications.
While medicines are vital to prevent and treat disease and to improve quality of life for older people, they also have the potential to cause harm. Inappropriate or incorrect use of medicines can have an adverse effect on health. A quality medication management system aims to maximise the benefits and minimise the risks of harm.
One of the main objectives of the guiding principles for medication management in residential aged care is the quality use of medicines, or QUM. This approach guides the maintenance of the resident's health, including the treatment of any illness, as well as the selection and safe use of suitable medicines.
The guiding principles for medication management also assist residential care facilities to develop, implement and evaluate site-specific policies and procedures to support those involved in assisting residents and to support residents in the medication management process. There are many influencing factors that affect medication management. People are now older and more frail when entering care. Residents' care needs are more complex, and residents' movements across care settings can challenge the continuity of quality medication management. It is your organisation's responsibility to develop a systematic approach and your responsibility to adhere to it.
There are 17 guiding principles, and you can see all of these in more detail in your learning resources. All must be incorporated, but for now, let's focus on a few. The first guiding principle, and central to the establishment of a quality medication management system, is the organisation's Medication Advisory Committee, or MAC. Each organisation should have or have access to a MAC. It's responsible for developing your organisation's policies and procedures that make up an effective medication management system. The MAC also monitors, evaluates and revises medication management policies and procedures to ensure their effectiveness is maintained.
Something Joyce has been running, so,
Yes.
so Joyce, could you please fill us in on the
Yes, I would like to, I've identified a problem when auditing the medication charts. Now, the written orders for the PRN medications are not clear enough as to when and why the medication can be given. Now you see on this chart, doesn't specify why the paracetamol, what the paracetamol was ordered for and how often it can be given. So I contacted the GP and the new order is much more specific.
All right, well, thank you very much for that, Joyce. That's a very important issue, and I clearly think we need to review our current policy relating to ordering of PRN medicines. So I would like to set up a subcommittee.
Part of the MAC's function is to prevent poor adherence to procedures that could lead to a critical event.
The medical response to Mrs. Davidson's condition was characterised by a failure to follow the established medication management procedures. There was also a lack of cross-referencing each day as medication was dispensed, and a delegation of duties by the registered nurse that was incomplete and was not managed effectively.
I'm just going to speak to one of the doctors.
Yeah, sure thing, I guess.
Yeah, awesome. Thank you. You'll be right.
The best practice for a cytotoxic drug that is accepted to be a high-risk medicine should have been to get the chart written up within 24 hours of return from hospital. The order and the medication should then have been sent to pharmacy to be packed correctly and highlighted as once weekly. They should have had a policy and procedure discussion at the MAC meeting around safe management of methotrexate, rather than the discussion about the PRN orders.
Other important guiding principles involve the reliable recording of medicines selected, prescribed and used for all residents. Whether using an electronic management system or written charts, accurate records support safe administration of medicines and effective communication of medical information between residents, healthcare professionals and care settings. The correct storage of medication is also vital. Medicines should be stored safely and securely in a way that maintains the quality of the medicine. Cytotoxic medications must be supplied separately and clearly labelled. Unwanted, ceased or expired medicines must be disposed of safely to avoid accidental poisoning, misuse and toxic release into the local environment. Your organisation should ensure that all staff are appropriately qualified, trained and authorised to administer medicines, and that administration practices are monitored for safety and quality. Another important guiding principle relates to the alteration of oral dose forms. Your organisation should ensure that residents, their carers and staff administering medicines know which oral dose medicines can and cannot be altered, either by crushing or chewing or in any other way.
Medication administration isn't just the job of giving the right medication to the right person. It's a chain of connected and important parts. It includes the assessment of the person's condition, evaluating outcomes, monitoring for side effects or adverse reactions to medication, and working within your own professional boundaries, scope of practice, and within the organisation's policies and procedures. Medication mistakes can occur at any stage along the chain of the prescribing process. Errors can occur with prescribing, documenting, transcribing, dispensing, administering and monitoring. All staff administering medications can intercept these errors through safe and vigilant administration ensuring the safety and well-being of people in their care. It's when an error goes unchecked, all the way to the medication being administered, that the most harm can occur.
In the case of Mrs. Davidson, appropriate and accurate medication administration was not carried out. There was an inappropriate delegation of the medication audit and medication administration to an enrolled nurse, Rajni Bashar, who was not fully trained to be deemed competent.
Simple but important steps can reduce errors in medication administration. It's recommended to use a standardised medication chart, which should include a recent photo of the person, with their name and date of birth clearly printed for identification purposes. The National Residential Medication Chart, or NRMC, was developed to reduce the administrative burden on prescribers, aged care staff and pharmacists when ordering, administering and supplying medicines. Importantly, the NRMC is resident-focused and has been shown to reduce incidents. Electronic medication management systems, or EMMs, are designed for safety and quality control in healthcare. Even with an EMM in place, the same system and quality checks apply, and it's essential that doctors' primary order is checked when administering medications.
There are certain rights that all care staff need to be aware of. The first right is the use of 2 identifiers to ensure you are giving the right medication to the right person. You need to check the medication you are giving is the one that was actually ordered, the right drug. You need to check the order is the right dose for the resident. Too much or too little of the correct medication can cause issues for the older person. The correct dose must be administered properly, the right route. You must ensure you are giving the medication at the right time and that doses are properly spaced. In addition to those existing rights are new rights. You need to check you have properly documented the medication, including the time, dosage and route of administration, so that you have a reference in the event of an adverse reaction in the older person. The right documentation. You also need to ensure the medication is given for the right reason. Does the medication and dose make sense? Always check to ensure the older person has had the right response to the medication. And finally, the person has a right of refusal, which must be respected.
Some facilities have a medication apron for staff to wear when conducting the medication round, so they can be identified and won't be disturbed. While this can assist, interruptions may still occur, and staff must ensure they are vigilant to avoid medication errors.
Of course, I'm just going to give Marion her usual and then I'll come down. Okay.
Studies have shown that nurses interrupted in the administration of medications had a 21.1% increase in errors. So it's critical that staff follow procedure and are accountable for their actions. It's vital that all staff delivering medication know how to calculate medication dosages. Refer to your learning resources for a link to sites where you can practice your skills and become familiar with all formulas.
Mistakes often occur when older people have trouble swallowing a tablet or capsule and they try to chew, crush or mix the tablet in food or drink. Some medications are designed to slowly release over an extended time. If the medication is altered or destroyed, it can be released too fast and cause a bad effect. If a person complains of difficulty swallowing or if there is a change, the person should be reviewed by a pharmacist before the medication is given or crushed and then provided.
Medications must not be crushed if they have labelling that indicates that the dose has an altered release characteristic. These include controlled release, sustained release, modified release, controlled delivery, and enteric coated. A list of medications that must not be crushed or require special precautions should be kept with the medication trolley and in the dispensing area. But this is simply a tool and should not be relied upon as definitive. Each organisation must have policies and procedures in place for the alteration of certain oral doses. These should be reviewed by the pharmacist and endorsed by the MAC team. There's a high risk of adverse reactions when medication policies are not followed.
Errors can and do occur at any point in the medication management process. So, having a regular auditing process in place for all parts of the system will ensure any issues are identified, appropriate actions can be taken, and quality outcomes are maintained.
The system failed Gwen Davidson. Quality medication management depends on a thorough system and on individuals working within that system to their professional standards.
There was a failure of the responsible staff member to accurately cross-reference the medication prescribed and administer it safely. This error was repeated down the chain of command and led to the death of Mrs. Davidson.
Regardless of what happens earlier in the medication management process, your scope of practice requires that you use your professional knowledge and skills when administering medication. If you're not sure or something seems wrong, you have a duty of care to report it. Remember, the goal of medication management is to achieve the optimum health outcomes for the older person. People's lives are in your hands.